I'd like to offer a welcome to the inaugural Blavatnik Family Women's Health Research Institute Symposium. This is our first. I'd like to extend my thanks to all of you here, faculty, trainees, and staff for being here and to support the Institute. I'd also like to thank the Blavatnik family, specifically Emily. They couldn't be here today, but we wouldn't all be here without her support, so thank you, Emily. The Department of Obstetrics, Gynecology, and Reproductive Science is pleased to collaborate with the Institute and is proud to support the Icahn School of Medicine's commitment to advancing women's health research. Over the past year, the Institute has flourished and continues to recruit wonderful research scientists to extend our knowledge in women's health. And now I have the honor of introducing Dr. Andrea Danaeff, and she is the chief of the Hilda and J. Lester Gabrieloff Division of Endocrinology, Diabetes, and Bone Disease for the Mount Sinai Health System. She's a professor in the Department of Medicine and a friend. I've known Dr. Danaeff for over 30 years. I was in the 6th grade, she was in the 4th grade. I won't get into it, but we've been friends ever since. Actually, we both started our careers at Mount Sinai. And we're very pleased to have you back. Her research has launched Mount Sinai to the forefront of international acclaim for PCOS and diabetes studies. And since 1985, she has had continuous NIH grant support, including being the first investigator to report that women with PCOS were at increased risk for type 2 diabetes. Her research group has also been in the forefront of studies on the genetic basis of PCOS as well. As a renowned physician scientist, Dr. Danaeff seeks to build on Mount Sinai's strength in research on diabetes, metabolism, and endocrine disorders. We're honored to have Dr. Danaeff as a colleague at Mount Sinai and are amazed by the dedication and energy that she brings to women's health research here. So please join me in welcoming Dr. Danaeff.
So it's really a great pleasure to be here and to follow Vivian. I had the honor of being at the Hunts Valley meeting when Vivian was announced as the director of the Office for Women's Health. And we've had the opportunity to collaborate over a number of years. And she's really transformed the concept of women's health and sex and gender differences. In fact, bringing in the science of that, going from the bikini concept of women's health to a much more broad-based concept. And what I hope to show you, and this will just sort of be a quick overview, but what the fundamental science of sex differences basis is. And I was the first director of the Connors Center for Women's Health at the Brigham. And this was in the late 90s. And I remember going around to meet people and to say that this was a very important scientific discipline, and meeting a member of the National Academy who was a very distinguished woman scientist and saying, you know, that sex, chromosomal and hormonal sex differences are important in biology, and literally being laughed out of that office. And we've just come a long way, as I say, and it's very, very much thanks to Vivian and all of the research programs that she initiated at NIH and her extraordinary vision. So what I want to talk about is just give you a little bit on the biology of why sex differences are important, both at the chromosomal sex level and the hormonal sex level, talk about epidemiology, and then just give you some disease examples of important sex differences. So sex differences are the combination of your chromosomal sex, your sex-determining genes, X and Y, and then how the gonad differentiates, because the gonad makes the gonadal hormones, the sex hormones, mainly estradiol and testosterone, which are very important in most of the phenotypic sex differences. And those hormones act during embryonic life, in the neonate, puberty, and in the adult. And so we have this whole combination of chromosomal sex and hormonal sex to give us our ultimate phenotypic sex. And as we all know, women have 2 X chromosomes, and men have an X and a Y. And please note how little this Y is. We'll comment on that in a minute. And it's been shrinking. And starting out at a disadvantage, guys. So we can, the egg and the sperm have half the chromosomal complement. And so when you get an X sperm and an X egg, you have a female, and a Y and an X, a male, and we can have disorders in this process, and so you can sometimes have extra X's, rare to have extra Ys. The X and the Y started out as just regular autosomes in evolution, and this is David Page at MIT's very, very elegant work. And so in our reptile-like ancestors, these were just like the other chromosomes. And then through evolution, here we are about 300 million years ago, the Y chromosome began to shrink and lose its ability to cross over and have recombination with its partner chromosome. And it's continued to shrink. So if we look in marsupials, the Y is even smaller. And as we get into mammals and monkeys, shrinking Y, and 30 to 50 million years ago in our hominid ancestors, we now have this Y that's unable to recombine with other chromosomes and continues to shrink. And there are some projections that the Y chromosome may even disappear. So the Y chromosome is becoming an ever-decreasing contributor to chromosomal sex. Now there's this section, SRY, on the Y chromosome, which is very important in, or key, in determining male sex and leading to testosterone production in embryonic life. So starting out, we have a gonad that can make either makes male and female hormone, and we have the precursors of the female genital tract, the Mullerian ducts, and of the male genital tract. And I think this conception is flawed, and as we do more research, we will find that being a female is just not the absence of maleness. But for now, the kind of developmental explanation is that if you have the Y chromosome with the sex-determining SRY, you make this hormone, Mullerian inhibiting substance, discovered by Pat Donahoe at Mass General, a very distinguished female scientist, also called anti-Mullerian hormone, testosterone, insulin-like growth factor 3, and then we have the repression of the Mullerian ducts, the growth of the Wolffian ducts, and the development of the male genital system and the production of testosterone, which then virilizes the external genitalia to get male-appearing genitalia. So externally, the difference between a male and a female fetus is the action of testosterone on developing, closing up the labial scrotal folds and penile development. And there are disorders here of sexual differentiation that can lead to defects in the appearance of the external genitalia. Now, we have, if you're a female, you have an X chromosome from paternally and an X chromosome maternally. And one of those chromosomes in the cells is always inactivated. So you only have one functional X, and it can be from mom or dad. And this is set to be a random process, but we're now beginning to appreciate that it isn't random, and that some diseases, like in some autoimmune diseases, one of the reasons for sex differences may be an imbalance in the inactivation of the X chromosomes with an overrepresentation either of maternal or of paternal. So now the sex hormones. So the gonad, whether it's a testis or an ovary, has the same enzymes determined by the same genes and makes both male and female hormones. It also makes the hormone progesterone, which women make during the menstrual cycle after ovulation. And progesterone and its related hormone, 17-hydroxyprogesterone, in the adrenal gland are further converted to our mineralocorticoid hormones, aldosterone, and also to the stress hormone, cortisol. But in the gonad, we have testosterone being the precursor for estradiol production by the ovary. So males and females make testosterone and estradiol. It's just a question, depending on the regulation and the enzyme systems, either within the gonad or in peripheral tissues, on the balance of that. In male target tissues, there's an enzyme called 5-alpha reductase, which converts testosterone into a much more potent androgen, dihydrotestosterone. So this dihydrotestosterone is responsible in males in particular for most of virilization, and whereas in females, the testosterone is aromatized into estradiol, and estradiol is the major female hormone acting. Then sex steroids act on target tissues via receptors that are intracellular and then translocate to the nucleus. Either in females, we have estrogen receptors, males, testosterone receptors. And what's very important about the biology here is that specificity on how these hormones act on different tissues is conferred by the cofactors in the nucleus, and they're also, these can be activators or repressors. And we've now, through drug discovery, understand that by manipulating some of the structure of hormone-like substances, we can selectively modulate the actions and have compounds that act like partial estrogens, so they can have estrogenic activity in some tissues and block estrogenic activity in other tissues. So this is now really a core of hormonal treatment for breast cancer, being able to modulate with drugs such as tamoxifen, peripheral hormone action. And there are selective androgen receptor modulators. The development there has been much less successful than in the estrogen field. But by understanding the basic biology of how sex hormones act has led to real progress in drug discovery. And one of the areas how one can say that by studying women's health, we've been also able to benefit men, because these fundamental insights have led to very important advancements in pharmaceutical science. So how do we put this all together in the adult? So the pituitary gland makes the hormones in a single cell, luteinizing hormone and follicle-stimulating hormone, which control the gonadal production of sex hormones. So the system is the same whether you're male or female. And in fact, LH, luteinizing hormone, is the hormone that stimulates testosterone production in males and in females. And in males, there's very little capacity to convert that testosterone via aromatization into estradiol. And so we have testosterone circulating in the periphery, then intracellularly in target tissues, In the males, we have a predominance of the enzyme system 5-alpha reductase that converts it into dihydrotestosterone, the more potent hormone, and so we get virilization. However, males can have some aromatase. They do make some estradiol. And at the level of the hypothalamus, which controls, the secretion of LH and FSH, there is aromatase. And in fact, much of male hormone action on the brain is not from testosterone, but is from the conversion of that testosterone into estrogen. So in men, estrogen production is very important in key peripheral tissues, but it's sort of made and consumed locally because of the local enzyme systems. Women, the regulation of the reproductive cycle with the menstrual cycle is very, very complex. Has to do, these hormones are secreted pulsatilely. LH early in the cycle stimulates testosterone production, and then this FSH, follicle stimulating hormone, as follicles grow, they develop the capacity to convert that testosterone into estradiol. So the major hormone circulating in women is estradiol, and it acts on peripheral tissues. Women do make some testosterone, and so there is some circulating testosterone. And again, depending on the enzymes in the peripheral tissues, estradiol can be made if there's aromatase, and women do have some 5-alpha reductase, so they can make dihydrotestosterone, and then estradiol feeds back to regulate its own secretion. So through the life cycle, we have very high, in this slide, the males are in blue, dotted lines are for estradiol in men, and women are in red, kind of pink, and dotted lines are for testosterone in women. So in utero, testosterone is mainly produced, and it's a male fetus, and we get the maturation of the external genitalia. Then at birth, there's a period of time right after birth when there are very high circulating sex hormone levels. That's called the mini puberty of infancy. And then those go down, and the sex hormone levels stay down until the time of puberty, when we see increase in estradiol levels in females and testosterone levels in males, and we also start to see a little bit of testosterone made in women and estradiol in men. And then women, at the time of menopause, which is about 52, have a marked decrease in estradiol production. And so with life expectancies into the 80s, women are spending 1/3 of their life now in a low estrogen state. And what's fascinating is that males have, because they continue to produce testosterone, it does decline slightly, but mainly after puberty, males have quite high testosterone levels. They can, from that testosterone, make more estradiol than a postmenopausal woman has. So men do have some a significant amount of estradiol compared to postmenopausal women, and those are important for bone density. So let's now start to talk about epidemiology. And I think we're all aware that women currently, particularly in the developed world, live and have a longer life expectancy than men. It's of interest that this sex difference in life expectancy only began at the beginning of the 20th century. Before that, the life expectancy in both sexes was about 45, and then we've seen an ongoing increase in life expectancy, but across, and I think this is fascinating, this female advantage across cultures, and here's the United States, and as in many metrics of health, we are way down compared to our other neighbors in this parameter. Men are living longer, and it's projected that perhaps by 2050 in the United States, men will catch up to women in life expectancy. Here are the leading causes, and this is United States data, of death in males and females. And importantly, heart disease is the leading cause of death in both sexes. So there's no sex difference in causes of death. Cancer is the second overall leading cause, and lung cancer leads to more deaths in women than breast cancer, although I think the perception in women is that it's breast cancer. And then there's pretty much similarity, though. Violent death is a larger cause of death in men than in women. Now, let's cardiovascular disease, which I've told you is the leading cause of death. But women before menopause are relatively protected. So if we look, this is women, this is men, and we just see that women start to catch up in cardiovascular diseases, and this is coronary disease, cerebrovascular, heart failure altogether, that they only start to catch up in their 60s and 70s. So they have about a 10-year delay to the prevalence rates that we see in men. Now, through research and aggressive statin therapy, male cardiovascular disease rates have really been substantially dropping since the 80s and really going down strikingly for quite a period of time. And this may be because women haven't been included in clinical trials in cardiovascular disease. There was a gender gap or sex gap, and women's rates of cardiovascular disease have only started to go down recently because there was really a lack of perception on the part of women and on the part of their healthcare providers about the cardiovascular disease risk in women and lack of attention to modifiable risk factors. And if you look at perceptions in women of disease risk, in the 90s, it was women felt, and this is surveys of women about what they thought their disease risk was, the 35% thought they had a much higher risk of dying of cancer, in particular breast cancer, than of cardiovascular disease, so a disconnect with the data. And through the work of the American Heart Association and a lot of the campaigns, the Red Dress campaign that you're all aware of, now in 2012, women's perception that they are at risk for heart disease has really increased. Women still fear breast cancer, probably disproportionate to its prevalence. And this has led finally to attention to modifiable risk factors. So now let's turn just to some examples of what the biology of some of these sex differences in disease risk that we're now coming to appreciate. And this is a nice summary. It's a bit of a complicated slide, and we're looking at sex differences in cardiovascular disease and the contribution of sex hormones. So it says either estrogens or androgens, and the orange is bad. And this is chromosomal sex. So these are very elegant studies where you can create mouse models that have one chromosomal sex and a different hormonal sex. So you can start to ask the question, how important is chromosomal sex, just your chromosome complement, versus how important are your circulating sex hormones? So for obesity, and these are animal models, estrogen is protective. However, having female chromosomal sex increases obesity risk, and I'll show you another more recent study of that. Atherosclerosis, if you're female estrogen, and this very complex area, it depends on the timing of the estrogen exposure, but certainly in premenopausal women, estrogen is a very important protective factor. But in males, androgens are also protective in many ways. And here, having extra Y chromosome increases your risk for atherosclerosis. So there is a common chromosomal disorder, Klinefelter syndrome, with extra Y chromosomes. Now, if looking for aneurysms, estrogen protective, androgens adverse, and then myocardial injury, estrogens protective, but female chromosomal sex. So we're now beginning to understand at a basic science level that both your chromosome content, there's a sex hormone by chromosome interaction in disease risk. So now with type 2 diabetes, if you're a premenopausal woman, you have a much lower risk of death from cardiovascular disease than a male. So these are the death rates per 100,000, and in women, less than 5 premenopausal women compared to about 5 per 100,000 in males. If you have diabetes and you're a female, that totally takes away the protection of being a premenopausal woman. And in fact, you have a greater increase in risk of cardiovascular disease if you develop type 2 diabetes as a premenopausal woman than if you develop it as a male. You'll have a 3-fold increased risk. So again, these age, sex hormone interactions and risk. If we look at sex hormones, circulating sex hormones, and disease development, if you're a male and you have low testosterone, you have a greater risk in longitudinal prospective studies of developing type 2 diabetes. If you're a female and you have higher testosterone levels, you have a greater risk of developing diabetes. So low testosterone being adverse in males, high testosterone being adverse in females. And if we look at fat distribution, there's a major sex difference in fat distribution. So we have, and this was popularized in the 1940s by Jean Vague, we have women with lower body fat and men with upper body fat, abdominal fat, so pears versus apples. And a lot of this difference in distribution is due to visceral fat. And men have more visceral fat than women. And men tend to be less sensitive to insulin, to have a condition, insulin resistance, to have more inflammation, whereas women tend to be more insulin sensitive. And one of the outcomes of the Women's Health Initiative was to show that certainly estrogen is an important determinant of that, because if you are using estrogen therapy, not replacement, you have reduction in type 2 diabetes risk, and women have less inflammation. And this is a study, and it's nice to see this coming out in such a major journal, and just recently in 2019, I think it shows how this field has grown, and really looking at gene by sex interactions and showing that if you're female chromosomal sex, you have less fat mass, more insulin sensitivity than male chromosomal sex. You have greater fat mass and greater insulin resistance. So that you can show that there's a chromosome and sex hormone interaction on disease risk. Autoimmune diseases, well, that's really very well known that most autoimmune diseases like lupus and thyroid disease and scleroderma and rheumatoid arthritis are much more prevalent in women than in men. except here we get into type 1 diabetes, which is an autoimmune disease, more prevalent in males. And sex hormones are very important in this. So high estrogen, like we see in pregnancy, improves cell-mediated immunity, but worsens antibody-mediated immunity. Progesterone, very high in pregnancy, also in the second part of the cycle, has anti-inflammatory effects. Androgens, male hormones, have immune suppressive effects, so they're beneficial. And then prolactin, which is a pregnancy hormone that's important for lactation, also is inflammatory. And I included this slide to remind me that there are important genetic factors too. And if you have the skewing that I mentioned of your X activation, or you have increases in X chromosome dosage, you have more susceptibility to autoimmune diseases. And one question has been raised that maybe even the Y chromosome, with a few of its old chromosome genes there, might have some autoimmune protection. And then the intrauterine environment, which we're going to hear about, antigens there are important. So I think in closing, I really like this slide. This is used in the field of sexual arousal, but I think many fields, areas of sex and gender differences, that women's physiology is very complicated, whereas men, they hit puberty, they have testosterone, and it just stays there. So I would be very happy to answer questions. Thank you for your attention.
I wanted to ask if you could talk a little bit more about some of the research going on looking at estrogen and cognition in later life, and talk a little bit more about the sex hormones. And I know that a lot of people are looking at that when studying kind of Alzheimer's disease and things like that. So can you talk a little bit more about that?
So one of the hypotheses about estrogen and menopause was that estrogen would be protective against cognitive decline and dementia. And this has been looked at now in a number of trials. In the Women's Health Initiative, where there was the women's memory study, there was no protective effect of estrogen on cognitive decline. In fact, there was a worsening from the estrogen replacement. So the Women's Health Initiative, women were many years, the mean age of the women was in their 60s, and so they had been many years estrogen deficient. So the hypothesis was maybe there's a timing effect of estrogen, and if you start estrogen immediately at the time of menopause, you'll get more of a benefit. And the studies looking at that have not supported that. They've shown that starting estrogen right at the time of menopause, there's no increase in cognitive decline. So you don't see the adverse effect that they saw starting it later, but there's no evidence that it's protective. Now, some of cognitive issues close to menopause are related to sleep deprivation, and it's very clear that estrogen therapy does help with sleep, and we still use it in early menopause for women who have very disrupted sleep. So in that sense, it can improve functioning. But I think as a panacea for Alzheimer's and cognitive disorders, it has not been supported by the data.
Thank you for an excellent presentation. In your most recent referrals in terms of the Women's Health Initiative studies, were those in the estrogen cohort that was started at various times related to menopause given estrogen alone, or were those all given estrogen and progesterone?
So I believe, and I would just have to check again, and somebody might know the answer to this, I believe these were the combined data. So they took the people who were so the estrogen alone arm were only women who'd had hysterectomies. And I believe the data from the women's memory study was both estrogen alone and estrogen and progestin.
Now I have the privilege of introducing Dr. Laura Riley, who is the Given Foundation Professor and Chair of Obstetrics and Gynecology at Weill Cornell and the Obstetrician-in-Chief at New York Presbyterian Weill Cornell Medical Center. She's a renowned physician scientist and practicing maternal fetal medicine specialist. Prior to coming to New York City this past fall, so I believe she's only been here for a few months now, she was the Charles Montreville Green and Robert Montreville Green Associate Professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School, and served as Vice Chair of Obstetrics, Medical Director of Labor and Delivery, and Director of Obstetrics and Gynecology Infectious Disease at the Massachusetts General Hospital. An internationally recognized expert on obstetrics infectious disease, Dr. Riley specializes in the treatment of expecting mothers whose pregnancies are high risk due to chronic illness or infectious disease. She also works with the CDC, the U.S. Department of Health and Human Services, and the American College of Obstetricians and Gynecology to develop practice guidelines for pregnancy care of women with Group B strep, Zika, Ebola, and influenza viruses. She's the chair of the Immunization Task Force at the American College of Obstetricians and Gynecologists. It gives us great pleasure that she's here with us today. Please join me in welcoming her.
Good morning, and thank you very much for the kind invitation. And also thank you very much for letting me be here on the same day as Dr. Pinn. I'm going to embarrass her and tell you all that I've known her since I was 16 years old. And I was in a biomedical sciences career program with Bill Wallace at Harvard when I was just trying to go to medical school. And Dr. Pinn may or may not remember this, but about 2 years into my stay at Harvard undergrad, it was a disaster. I had a then second year radiology resident who was going to write my letter for medical school, who looked at my record and said, "There's no way you're going to get in. You're the worst candidate." Thankfully, I didn't listen to him. I listened to Dr. Pinn and all the other people who were supporting me at the time. So here I am. So I think all of us probably have a few of those stories. So I'm also going to say thank you for inviting me and giving me this topic. So this is not my area of expertise, and I have to say I knew very little about it before the last month and a half when I was reading furiously. And so it's going to change my care. So I'm basically a clinician. I do a little bit of research, but I really am a clinician. And so I tend to think of research questions when I'm sitting in front of a given woman, not even the entire masses. And so this was an interesting topic for me. And these are my disclosures. They're all on infection, which is my area of interest. So I'm just going to talk about three pregnancy-specific conditions that I think there's lots of data suggests are linked to poor outcomes for mothers. And then talk a little bit about the biologic plausibility, but I'm really using those slides for kind of as a break in the middle. And then finally, just to mention or propose some interventions which may be really critical to improving the lives of women after pregnancy. So as I said, I'm a clinician, and so I think in terms of seeing the patient in front of me, and I was knee deep in reading all this data, and then this woman came to see me actually maybe a month and a half ago. And so it's a 29-year-old African-American woman who had a recent poor pregnancy outcome. So she was otherwise healthy, and then other than having had a family history of preeclampsia, which is pregnancy hypertension, And so this was her first pregnancy. It was complicated by some fetal growth restrictions. So the baby wasn't measuring what it should at 23 weeks. And then she was, sort of followed very carefully until about 26 weeks, when the growth was noted to be markedly diminished on an ultrasound. And they also showed that the flow through the placenta, through the blood vessels in the placenta, was really quite turbulent, which, for those of us who are OBGYNs, we know that that's starting to be something bad. So 2 weeks later, her blood pressure was going up, and it was really quite high, but she otherwise, felt well. So despite a whole lot of monitoring and bringing her in the hospital and giving her baby medicines to try and mature the lungs faster and all sorts of heroic things, she awoke one morning with bleeding and told her husband, "I'm bleeding," went to the hospital right away. And basically what happened to her is that her placenta separated and her baby died at 30 weeks. And so these devastating outcomes do happen. And it's interesting, I think, as an OB, I was thinking one thing as I was as this patient was sitting in front of me. But I have to say this talk made me think of a few other things that I'll bring up at the end. So hypertensive disorders of pregnancy, I'm lumping them all together, and obstetricians in the audience are probably cringing. How can she do that? But we're going to do it for today because I have 20 minutes to tell you about this. So we're going to include, and many of the studies actually do include all of these things in one lump sum. Chronic hypertension, or women with gestational hypertension, meaning their hypertension comes in the middle of pregnancy or during pregnancy and usually resolves soon thereafter. Preeclampsia is high blood pressure and spilling protein in the urine and all sorts of other crazy things that happen. But again, it's, hypertension is really the hallmark. And then HELP is a horrible version of preeclampsia, where all sorts of things go awry, like liver disease and low platelets and all sorts of other things. Worldwide, about 7.5% of pregnancies are complicated by preeclampsia or gestational hypertension. So it's fairly common when you think of it, just even in the US alone, 4 million births a year. The other thing that I've seen in the literature, which I never thought of before, but they're called placental syndromes. And those syndromes include preeclampsia, placental infarction, placental abruption. And part of the reason is because we know that for people who have hypertensive diseases of pregnancy, the placenta is affected. And so we see blood vessels through the placenta, which are way more constricted than normal. Or we see, even worse, those blood vessels are completely blocked off, and you see infarctions, and it's really a disordered mess. So this is looking at these hypertensive diseases during pregnancy and the long-term cardiovascular risk. And so this is just a long list, but there are many, many other studies, and this comes from one of the more recent meta-analyses. And just looking at this last study, for instance, I just pulled one out, and there were over 800,000 women looked at. And here they looked at 3 different things: gestational hypertension, mild preeclampsia, meaning the blood pressure wasn't that bad, the lab values were not that awful, and then they looked at severe preeclampsia. But in any way you looked at this, and you looked at cardiovascular events, the relative risk was not insignificant, right? It was 2.8, 2.2, and 3.3. So clearly there is something in the literature, and these studies come from all over the place, which suggests that there's something about hypertension during pregnancy or hypertensive diseases during pregnancy which can lead to cardiovascular risk later for these women. And then this is just another study, the CHAMP study, lots of people were sort of up in arms about. And I think that the interesting thing is that it looks at over 1 million women. They had 8.5 years of follow-up. And again, this study then looked at, gestational hypertension or preeclampsia. It also looked at having some hypertensive disease, but then you can see poor fetal growth, hearkening back to the patient that I presented, poor fetal growth, intrauterine fetal demise, suggesting that there really was a major impact on that placenta. And again, the odds ratios for cardiovascular disease later in life were really quite high. And then this looks at placental syndromes themselves and short-term cardiovascular risk, which I also found quite interesting. So in this particular study, this was a retrospective cohort that was done in Florida, and they took women from a huge, range of ages, and they looked at over 300,000 women, compared those with placental syndromes during pregnancy and those without. And what's interesting is this was a short-term follow-up after pregnancy, which is about 2 to 5 years. And one thing I should mention, for those of you who don't do obstetrics, we often tell patients, you know what, you had preeclampsia, the treatment for preeclampsia is delivery, and now it's all over. Your baby's delivered, and your blood pressure will go down. Usually your blood pressure goes down. Some women need an antihypertensive for, 4 weeks, 6 weeks, 8 weeks. But in general, it resolves. But now I'm thinking to myself, I need to be really cautious about using that word resolution, because maybe the preeclampsia resolves around this pregnancy, but now we're talking about something that really could be a lifelong risk. So anyway, I digress. I learned that from Dr. Pinn. I get into it, and then it's really hard to turn it around. At any rate, I think what is important is that even short-term cardiovascular risk, which is what they showed in this study, is not insignificant. They found that after adjusting for, multiple sociodemographic factors and other pre-existing conditions, that those women with placental syndrome still had a 19% higher risk of going on to cardiovascular disease, even in the short 2 to 5 years after. And I think that the other issue is that these women, sort of the events were things like they would go and they would need, evaluation for chest pain or shortness of breath or some other cardiovascular event. It's not an insignificant amount when you're looking at those people who are interested in health economics, right? Because they go for those evaluations. And in this study, those women had a 5-fold increase in healthcare costs during that short 2 to 5 year follow-up. And so this looks at those women who have recurrent preeclampsia, recurrent cardiovascular disease issues. And so some of you are saying, well, how often does that happen? Well, we do know that women who get preeclampsia maybe at 39 weeks or 40 weeks in their first pregnancy, many of those women will have 4 or 5 more pregnancies, and they'll never see preeclampsia again. The women who are at particularly high risk, though, are those women like the patient that I mentioned to you who develop preeclampsia or hypertensive disease of pregnancy earlier at 29 weeks, 34 weeks, 32 weeks. Those women are a little bit different, and they have a higher recurrence risk in subsequent pregnancies. And what this study looked at was the long-term mortality risk following recurrent sort of episodes of hypertensive disease in pregnancy. So, preeclampsia for 3 pregnancies or preeclampsia for 2 pregnancies. And they again looked at a retrospective cohort looking at birth and death certificate data over a long period of time. And this was done in Utah. And they found that, if you had more than one affected singleton pregnancy, and in this particular cohort, they looked at, did you live in Utah for more than a year, so that they could actually capture your data. And they found that women who had more than two or more hypertensive disorder pregnancies had really high increased mortality from all causes. And interestingly, if you look in the top panel, this issue of having a greater mortality was really focused in women who were less than the age of 50, right? So that may sort of get back to what Dr. Geneyev was talking about with the estrogen and progesterone. I don't know. I was trying to put it together very quickly when she was talking, but it's interesting to me that this increased risk is all, it seems to be heavily related to those women who are on the younger end. And so there may be something quite particular here about pregnancy. And then this is one of those, slides you can't believe people actually put it up, but what I really just want you to focus on is just look in this forest plot where the risk is with recurrent preeclampsia. Every single thing that you can look at, hypertension, ischemic heart disease, heart failure, cerebrovascular disease, and any cardiovascular event and hospitalization, all of those things are increased when you've had preeclampsia more than once, during your reproductive lives. So is there biologic plausibility? Well, yes, there is. We know that endothelial dysfunction is really the hallmark of preeclampsia. And there's other features that we see in young women with preeclampsia that make sense because then, later in life you're seeing these cardiovascular issues. We see atheromatous plaques and dyslipidemia during pregnancy. Chronic inflammation is the hallmark of, some pregnancies. Insulin resistance as well. And then pregnancy itself is a prothrombotic process because we know that there's a cascade that is increased during pregnancy for which pregnant women are at greater risk for blood clots, even without preeclampsia or anything else. I think also clearly there are many shared risk factors between women who have hypertensive disorders of pregnancy and then those who go on to have cardiovascular disease, both genetic factors as well as diabetes and hypertension. Insulin resistance becomes very important. And many people who sort of write about this talk about the fact that pregnancy is a stress test. I can tell you parenting is a bigger stress test, but that's another conversation. But we do know that pregnancy is considered in some ways a stress test. And basically just the physiology of pregnancy, if you think about it, by about 20 weeks into pregnancy, the blood volume's 2 times what it normally is. As I mentioned, there's increased clotting factors. And then we know that there are inflammatory markers that, really surge at various points in pregnancy. And if they surge at the wrong time, you end up with a preterm baby or various other things go awry. But there's also hyperlipidemia and as well as insulin resistance in just the normal state of pregnancy. So there's you can see that there is an overlap. So moving on. So this was something that I think I was not so well aware of. And thank you, Liz, for making me do this topic. There is increasing data and as you can see, huge number of studies looking at the risk of cardiovascular disease later in life for women who have had a prior preterm birth. And I think what's hard about the preterm birth story is that we know that the reasons for preterm birth are so heterogeneous. Some are spontaneous, and by spontaneous, you just show up and you deliver at 32 weeks and no one really knows why. Versus there are indicated preterm births where a big chunk of those are related to things like preeclampsia or diabetes or growth restriction, et cetera. But interestingly enough, even when you try and parse those things out and put things together, in this particular meta-analysis, they tried to look at different confounders like age and ethnicity, education. They looked at obesity and hypertension. They looked at preeclampsia, and they tried to, put it all out there. And interestingly enough, even when you try to look at all these different confounders, there seemed to be an increased risk for cardiovascular disease. And in this particular meta-analysis, it was 1.56. The risk ratio was 1.56. It suggests that there is something about having a preterm birth that then later increases your risk for cardiovascular disease later. I find this one a little harder to, sort of put together because I think there's so many confounders, but I think it's certainly worth thinking about. And then this was looking at another meta-analysis looking at preterm birth and cardiovascular disease. I think the interesting thing here, which makes a little bit more sense to me, is that the risk was actually greatest if in fact you had an early preterm birth. So a preterm birth less than 32 weeks gestation. And in addition, they also found that if your preterm birth was indicated, i.e. somebody like me said, you have preeclampsia, you need to deliver at 32 weeks, or the baby is growth restricted, suggesting there's something wrong with the placenta, those people were at increased risk for cardiovascular disease. So I think in some ways that piece makes much more sense to me than the person who shows up with the, just drops the baby out. Harder to understand, but I think, for those of you who are looking for research projects, this might be a good one, because I don't think that the story is over. So the biologic plausibility for preterm birth, I think, again, we know that it shares many of the common risk factors with cardiovascular disease. And I've mentioned, sort of spontaneous preterm birth, even the cascade that we understand, the pieces of it that we understand are related to inflammation and cytokine activation. We know that, increases in IL-6 and others will increase the risk for preterm birth. And then we also know that there are those with indicated preterm births, again, who go on to then because of hypertension or growth restriction and other poor outcomes. The thing that is a little bit interesting about the preterm birth story is that I did find a few studies which show that some longitudinal studies that show that women who have a similar lipid profile and similar blood pressures and inflammatory markers as of those who were born at term versus those at preterm, it makes me wonder if the linkages are the same, because if there's no change in their lipid profile and there's no really change in their inflammatory markers, maybe that isn't the reason that these women are at greater risk for cardiovascular disease. So I think that this is one that more study needs to be done. So I'm going to just do the third one, which is gestational diabetes, and I have to say I did my slides, then I looked at who was speaking, and I said, there's no way in hell I'm talking about diabetes in front of Andrea Donaev. That is not happening. I'm not that stupid. But it was one of those things where I couldn't actually not talk about it, so I'm not going to do a great job, but I am just going to hit the highlights. At any rate, so gestational diabetes in pregnancy. So these are women who are going to, in many ways, they basically have insulin resistance. And we know that that's a normal state in pregnancy, but there are some women who have even more insulin resistance. And we do, in general, we test all pregnant women at about 28 weeks gestation to see if that is something that's meaningful. What we're supposed to do, interestingly enough, is then retest these women if they've been given the diagnosis of gestational diabetes during pregnancy, and they've either been treated with a diet or insulin or sometimes hypoglycemic medication. They are supposed to undergo a 75-gram glucose tolerance test at 6 to 12 weeks postpartum to see if this is resolved. And it's interesting. Lots of women don't do it. Only, I would guess it depends on your patient population, but I would say in Boston, we saw maybe 20% of women actually show up for the 6-week visit, and then even fewer actually show up for more testing, which I think is an opportunity that we'll talk about later. At any rate, I think that the real, what's known is that some percentage of those women, and actually a fairly high percentage of those women who are diagnosed with gestational diabetes during pregnancy, will develop type 2 diabetes later in life. And it does depend on, in some studies, what their risk factors are and the length of follow-up as well. So that's why there's this huge spread, 36% to 70%. What I tell patients, because most people can remember this, is that 50% of women by age 50 will develop gestational diabetes. The patients can remember 50, and they all are like, oh my God, I'm not that far away, especially the women that we're seeing nowadays. At any rate, insulin resistance, we know, promotes atherogenesis as well as inflammation, and we know that those, as we've discussed, are vascular risk factors. So it makes sense. And so here's another one of those plots, which basically shows all of the data that we have shows that those women with gestational diabetes, and this is whether you're treated with insulin or whether you're just diet controlled. So it's really not related necessarily to anything other than just having insulin resistance, that these women are at great risk for future type 2 diabetes. And then when you look at coronary artery disease development and gestational diabetes, I think that this is an interesting study. This was in young adults, which is sort of what makes me go, ooh. They looked at over 2,700 women were enrolled, and they studied over 800 of them with a history of gestational diabetes. And what they did, interestingly enough, was that they measured the common carotid intima media thickness. And I think what's interesting and what's a little bit disconcerting to me is that they found, whether or not it's significant, I think is not as important as the fact that they found that there were already changes in their vasculature at such a young age. It suggests that there is some early atherosclerosis that can occur with these women who have had gestational diabetes during pregnancy. And it was independent of BMI, which I thought was also kind of gave me a little bit of angina. I think that I'll be way more careful with patients who don't show up after to try and track them down. And then this looks, again, at glucose intolerance, or even, and we know that most of that is insulin resistance, and future atherosclerotic disease. This was another retrospective case control study that was done over a 12-year period. And they looked at 800 women who developed some kind of atherosclerotic morbidity. And some of them were, major or minor, or just needing a cardiovascular evaluation. So again, if you're in the healthcare economics world, you're thinking this is not an inexpensive endeavor here. And they found that higher glucose levels during pregnancy, now you didn't even have to have the diagnosis of gestational diabetes, but just having higher glucose levels during pregnancy and some glucose intolerance led to higher rates of long-term morbidity. So that, for me, as one of those practitioners who's a little on the loosey-goosey side with the sugars, people come in, you tell them to check their sugars every, 4 times a day, and I feel so sorry that they have to prick their finger, and so when it's a little bit high, I'm like, just do a better job next time. I think I'm going to be a little bit more careful going forward. I think that there may be some meaning here that needs to be related to patients. So I'm just going to finish up with sort of the weight gain story and retention, because I think that it all comes together here as well. So just to summarize, I think the data is really very clear about hypertensive diseases of pregnancy and long-term cardiovascular risk. I think that the data is very clear about gestational diabetes and diabetes during pregnancy for all sorts of reasons. I think the preterm birth story may be a little bit more complicated, but may also just be all wrapped up in those other two. And then here's something else to consider about pregnancy would be weight gain and retention. I like this graphic, and sometimes I have it in my office. The patients don't like it as much as I do. But I think this is true, and this is many of us who have had kids will tell you that this is so true. It's unfortunate. But, in your first pregnancy, gestational weight gain is for a reason, and I'm not trying to knock that at all. Your BMI goes up, there's greater fat mass, and there's greater visceral fat, and that's, totally to be totally needed to support the pregnancy. I think what's difficult is that the gestational weight gain that happens during pregnancy, even if you gain what you're supposed to, which most people don't, it's difficult to take it off. And then people get pregnant again. And then once you've had the second one, I always tell my patients, if you didn't get rid of it after the second one, it's yours for life. So it is what it is. It is the truth, right? Okay, so the people who are laughing, they also know that I am telling the truth. It's not a nice message, but it's the truth. I think that it's important to know basically over a 5-year period, about 89% of women who have a normal weight BMI prior to pregnancy will become overweight or obese, and that's because you just don't lose it. You just don't have the time, the energy, the whatever. Basically, there have been many reports that suggest that excess weight gain is still with you 20 years later. I think what's important about that is that we know that, the metabolic programming that happens and the issues that, we are stuck with later in life, also, not only do they stick with us later in life, but they also have an impact, a well-known impact on the baby. So, trying to explain that to patients and make it meaningful is really difficult sometimes, but I think it's necessary. I do think that the weight gain and retention is also probably part of this cardiovascular disease later in life story. How it all comes together, I think, is difficult, but clearly it's part of the story. And then I'm just going to leave you with this last one as another part, a lovely part of pregnancy that probably is not helping us later in life. And this is a schematic that I think sort of, is helpful because it shows that, during pregnancy, there are, as we all know, it's difficult to sleep for a whole bunch of reasons. Much of the real sleep disorders, meaning, sleep apnea, it's been documented in about 10 to 30%, as many as 30% of pregnancies, so it's not nothing. And the risk factors for those sleep disorders have been noted as, gestational diabetes, hypertension, preeclampsia. And it's interesting because all of those things then sort of lead to this very same pathway that we're talking about, which later could lead to cardiovascular disease later in life. And sleep disorders are associated with an increased risk for cardiomyopathy, VTE, anesthesia complications, maternal death, et cetera, all of those, sort of immediate things that we're all worried about during pregnancy. But I think that the changes that then occur are the things that we now need to be worried about that lead to cardiovascular disease as women age. I didn't mention, but on that last slide, it's interesting. I was trying to figure out, so what do you do about it? Because, I know it's difficult. I don't know, who takes care of patients, but even once patients identify themselves as someone with a real, sleep apnea problem, the anesthesiologists are all like, did you get the CPAP machine and whatever? Like, try and get a CPAP machine. That takes you the whole pregnancy to get the sleep study. The pregnancy's over by the time you've done the sleep study, and now they're going to get the sleep apnea machine, and actually the data doesn't actually show that it helps. So it's interesting. It helps one thing, but it may not help them later in life. So let me finish with this, which is, pregnancy is a really unique time. I think that for many women, it's the only time that they interact with the healthcare system. It's particularly important depending on where you are, and I still don't know the politics in New York, but in Boston anyway, women who have lower socioeconomic means, they have good coverage during pregnancy and up to 6 weeks. And after 6 weeks, they're cut off. Everything is cut off. And that becomes a problem because sort of what we know from what I've just told you is that linkage to care after the pregnancy that's complicated or even uncomplicated becomes an important aspect of how we're going to improve women's lives. And so, the fact that the 6-week visit is sort of, boom, you're done, is problematic. I think also that there probably are many low-cost and high-tech interventions which merit further exploration. Not only how do we engage women in healthcare after their 6-week visit, but also, are there things that we can do to improve their understanding of their risks of cardiovascular disease? Are there things we can do to improve the likelihood that they're going to do the DASH diet when you send them out of the office with maybe that piece of paper, if you can even find it in your office? Behavioral interventions also, there are very good studies which suggest that behavioral interventions when started during pregnancy actually have the best success postpartum if you can reinforce them. But again, it's important to have that linkage of care, which I don't think we do very well. The 6-week postpartum visit, I think many people, many obstetrician gynecologists are like, okay, that needs to just be done. We need to stop and start all over again. And possibly my thought is, after years and years of practicing, is that we need to probably focus on different things. I know lots of patients come to see me at their 6-week visit, and really they just want to show me their baby pictures. They don't really want to go over what went on and what needs to go on. So I think and I am just like anybody else. I fall into that same trap, looking at their baby pictures and talking very little about the things that are important. And then the only other issue that I would mention about the 6-week visit is that lots of studies show that very few women actually access the 6-week visit. And so that's something that we have to sort of do a much better job about. If we made it more of a valued visit, I think that people would somehow make their way there. And then, so my consultation, so getting back to that unfortunate patient who had the demise, that was her first pregnancy. So, this is what we did. We reviewed her high risk for preeclampsia again. We talked about antihypertensive medications and how it's really limited use during pregnancy. It's not really going to change the architecture of the placenta. We talked about, I encouraged her to, weight loss and diet and exercise. And I also said meditation, absolutely critical. We talked about blood pressure monitoring, and we talked about baby aspirin in the next pregnancy. So then I harkened back to, I've now done all this research on long-term cardiovascular risk. So here was the interesting thing, and I'd be interested to hear what people think. So what I was stuck with sitting in the room is the patient and her husband were focused on the next pregnancy. When and how do you discuss the subject of long-term cardiovascular risk with someone who's sitting in front of you at age 29 wanting another pregnancy? Meanwhile, I'm like thinking there's all this data that I should be talking to you about because 39 might be a really bad year for you. So I just think that that's something that we, as providers need to think about. And I think it's a great area of research about how are we going to do that and how are we going to do it for such a huge number of people. As I mentioned, 4 million births in the US a year. And preeclampsia is anywhere from 7 to 10% of those women. Gestational diabetes can be as high as 9% of those women. So there's, a good portion of women who are going to be at risk. And with that, I will close.